Well, thank you for all of your time today and for welcoming your first panel of the morning. I think it's not a surprise to any of us that today we are at a very significant social, economical, political, and technological point of change within healthcare. And there's been such expeditious innovation that's been happening all over the globe and occurring in so many facets of people's lives, rapidly informing consumers, as well as driving competitive markets and generating a tremendous amount of competing messages as part of that. And so when we look at the root of why we're all sitting in this room here for patients, we know that there's this ever-growing demand of time and attention that's really being taken from those who receive care and is compounded by the decreasing capacity for healthcare clutter, as we might call that. And so when we look at what people are really looking for in their lives, it's not that. And they need to continue to receive great care now and going into the future. And that really leads us into our first panel topic, which is around healthcare consumers and the patient experience. So for the next 60 minutes, we're going to discuss different needs and trends and topics around potential changes in the future of healthcare and really consider that in our current as well as our projected landscapes over time. So as providers and leaders within healthcare, we just ask that all of you share what you're willing to share with us, just around personal thoughts, anecdotes, stories that really have meant a lot to you in your career and can help inspire us as researchers, designers, engineers, prototypers to be able to innovate and create really meaningful solutions that have real potential to impact people's lives and expand healthcare in a really rich way for people. So we have a few themes that we're going to talk about within the next 60 minutes. And so we're going to touch a little bit on value-based care and different consolidations that are happening within the United States, as well as coordinating care and how reimbursement affects that. We'll dip into what it means to talk about healthcare consumerism and how that's affecting everybody on the planet, as well as thinking about how education is provided to providers, as well as how we manage staffing to care for people at the end of the day. And then hopefully get into a little bit about generations in aging populations and talk about how that's affecting care today as well. So I want to do a few introductions here. We're going to go through, so first, Dr. Chan, thank you for being here. For those of you who are meeting Dr. Chan for the first time today, he is a world leader in healthcare technology and innovation. He's been an advocate of Worrell for a very long time, so he's very familiar to some of you in the room. And he's been partnering with Dr. Colleen as well to really transform the quality of emergency care medicine. And he focuses on how to advance value-based care and meet the needs of the growing geriatric population. So he's contributed to incredible results for literally thousands of people, and also along the way developed a lot of partnerships with local, state, and federal agencies. So a tremendous amount of innovation and design work coming from him, as well as great care. So if you want to share further about yourself, please do.
Well, I'm not sure who you're describing there. The one you asked for anecdotes, and yeah. I would say the one anecdote I learned more about the healthcare system taking my father and my mother through the system itself. Right, that was an incredible experience. You see all the holes, all the pitfalls, all the problems, and it's given me a lot better insight into what we need to do to improve the system. So I'm sure many of you are in the same situation where you have relatives or you yourself have gone through the healthcare system, and it is rather eye-opening, I would say.
Okay, my turn. Dr. Warren Ellsworth from Houston. So let me read the formal bio, and then we'll ask you for maybe a quick anecdote yourself. So Dr. Ellsworth is committed to improving people's lives through plastic surgery. As a medical director of the Plastic and Reconstructive Surgery program at Houston Methodist and owner of his own practice. He uses his expertise in expertise in reconstructive surgery and microsurgery to transform the lives of patients. He shares his expertise with the world by prolifically publishing his latest research in academic journals. Dr. Ellsworth has been appointed to many leadership positions within the field of plastic surgery, and he currently serves as the diplomat of the American Board of Plastic Surgery and is a fellow of the American College of Surgeons. So we had the pleasure of having a conversation with Dr. Ellsworth, and really fascinating space when really a micro subspecialty almost, if you will, where you practice, especially in reconstructive surgery and the focus there. The thing that really kind of struck me is something that may not be perceived as essential, but is very innovative and also kind of a very human side to that. And I think that is something that we're interested in hearing a little bit about today. But maybe you share an anecdote about yourself.
Sure. Thank you for the kind introduction, Matt. I practice in Houston, and as you said, I do a lot of microsurgical breast reconstruction after cancer. We can delve into that a bit later. Something interesting about myself. Well, something different. My father was an international operatic tenor, and so I grew up in the opera houses around the world and spent most of my life, I would say, up until about high school in Europe and wherever his career took us. So that offered an opportunity to see a lot of different healthcare settings, in all honesty, and not all was good, but not all was bad. So I've tried to bring some of that to my practice, and I studied music in college, which is a little bit different. I did classical voice and orchestral conducting, neither of which I do in my plastic surgical practice. But my field is one that melds art and science, so it just made a lot of sense. Thanks for having me.
Yeah, thank you.
Great. Wonderful. So Dr. Steele next. Dr. Steele is an experienced anesthesiologist. He's also a hospital leader and an expert on economics of value-based healthcare, as well as rural medicine. He has a lot of passion and enthusiasm for research and innovation, and we've had the pleasure of working on a project together just last year. And not only on top of all of that work, he also is Chief of Staff and Chief Quality Officer at White River Medical Center, where he has led the facility to become named as one of the top 100 rural and community hospitals in America by the Chartist Center for Rural Health. So huge advancement for that institution. And he's dedicated to aligning incentives of administrators, patients, providers, and advocates for more progressive models of care that can really be customized to meet the unique needs of every single patient. And he, when we spoke to, it was really fascinating to be able to hear how in the future, thinking about how we can logarithmically deliver better care. And so we're excited to hear more about that too. And fun fact, he has chickens. So that's potentially topic of conversation over the break. Yeah. Do you want to share something about yourself?
Yeah, well, thanks. I figure you assumed, being from Arkansas, that I would have chickens, so I wanted to make sure I met that stereotype. That's critical. I was fortunate to do anesthesia. I really enjoy that, and I've had some interesting perspectives because doing anesthesia and then going into an administrative role was interesting, and then we've kind of combined that with doing administration regarding our clinics and kind of leading our ACO, and it's a unique perspective because I get to work with a lot of primary care providers that I thought I hated the clinics and never wanted to go near them when I was in training, and apparently what I've learned through interacting with everybody is I don't know what I don't know, and that's why coming to a meeting like this is to be honest, a vacation for me, because I get to meet so many people that are doing things that I don't have a clue about. And it's so neat to be able to hear what they're doing and really think about different areas like that. So it's inspiring to be able to try and hear and learn more from what everyone else is doing. So thank you so much for the opportunity to come here.
In our cleanup batter position, Vous, right? So let me introduce you formally. Vous is a nursing director with experience supporting a wide variety of surgeries. His close contact with patients, empathetic style of caring, and 14 years of experience has led to his expert understanding of their current state of the patient experience in the operating room and how it can be improved. At the Hayes Valley Surgery Center in San Francisco, California, he currently is involved with plastic, urological, podiatry, and orthopedic surgeries. Kui, when we spoke with him on the phone, really interesting because, Kui, I think more than anybody, you've been at the front lines of healthcare in a variety of different settings, both community, urban hospitals and surgery centers, and now in maybe what some might consider upper class, a different style of surgery center. And so you've had a variety of different experiences and are intimately involved with the patient experience. And that really came through when we spoke to you. So maybe share an anecdote or something about yourself with everyone.
Yeah. Well, I've worked at many healthcare facilities, from Cedars-Sinai, taking care of celebrities and billionaires, to the county hospital where you take care of the poor and the indigent. And the one thing I see is we're all the same, and we come in for the same thing. We all have either stomach pain or heart pain and chest pain. But what's the difference? Going to a county facility or Cedars-Sinai or Stanford, a private facility, is the patient experience, right? Whether it's the smell or the design or the feel that you get, okay? And living in San Francisco, the biggest thing that we see driven healthcare right now is tech. We're Silicon Valley. We're home of Yelp, Twitter, Google, Yahoo, iPhone, and we can go et cetera, et cetera. And so I do want to talk about one case here that we had at our center. And the best way we learn about things is just from patient interaction. And so our medical director, when he first told me, bring me on to the organization, he said, Kui, you got to do half management and you have to be half frontline. You got to know what the patient has experienced. And I'm coming from a surgery center where it's all about the patient experience. Okay, this is the difference between patient having to be there and wanting to be there. Okay, we're not a hospital where you break your arm, you break your leg, you have to go get emergency surgery. You're here because either you want that experience, you want to know who's taking care of you, you want to get in and out. And I want to tell this story that we talked about earlier. We found out about this later. There was a lady in her 60s. She came for a procedure, and to summarize, she didn't have the great experience. And we in management didn't hear about it until she decided to go on social media. She went on Yelp, okay, and wrote a review for us, okay. And it wasn't a 5-star review, just to say. But what's interesting enough is, in the review she said surgery went well, okay. The biggest thing she noted was she called, and we had some logistical problems, and it's always that one person, right? It wouldn't happen any otherwise, but she came to the center that day and the phone went down. AT&T went down for 15 minutes. She couldn't get into the building, and that just threw off her day, okay? She called the center the next day and she's like, I want to talk to someone about my care. And she said that someone will call you back within 2 days. Well, someone in our business side didn't call her back. So she felt like she wasn't heard. So she decided to go on Yelp and write this review, mostly based on that, okay? And she had some anesthesia issues based on what she said. She felt like her tongue was damaged or this and that. And so, it took up quite a bit of time for the medical board and our anesthesia director. We thought maybe it would go med legal and stuff like that. And so, I called her, everything was fine. But then you fast forward 5 months later, she comes back for another procedure. So we weren't sure why. I called the doctor, I called the patient. She said, Kui, the care was great. It was just, she was just so stuck on that the fact that no one called her back. She felt like she wasn't heard, and no one cared. And so, we put a lot of process improvement steps to move forward. Our policy now is like, as soon as you get there, someone's gonna come down and take you up. Okay, we want to make sure that the phone isn't down or the intercom isn't down. You don't get stuck in the elevator. But that we always talk about these cases during meetings so that we can understand that we want to make sure every patient has a great experience. And so.
Great. thank you. I think that's a perfect transition as we go into some of
Yeah.
our topics.
Yeah, for sure. I think that, well, first of all, thank you to all four of you for being on this panel and our other physician guests here. One thing that's really been standing out to me as we've been able to get to know each other just briefly is the level of conversation can change so quickly, whether we're talking about those intimate moments of delivering really empathetic care to people, to this high-level conversation about strategy and value-based care and how we make that shift and how hard it is going to be to make that shift. And so, so thank you to all of you for that. We recognize that each person on our board is not only such a strong practitioner, but just a true leader and innovator in so many different ways, scientifically, from a service standpoint and beyond. So we're excited to dig in a little bit further here. So our first theme of this panel is around value-based care and as well as consolidation of new companies. So when we think about value-based care, there's this massive paradigm shift that's been happening, moving from fee-for-service into value-based care. And what comes along with that are big changes of how healthcare is offered, how it's measured, who the players are, incentives and payments. Everything is changing drastically, and that not only affects the patient experience, but it also affects how providers work together as well as work with other entities moving into the future. And so I want to just kind of dive in here, Dr. Chan, and ask you, how do you see value-based care making positive strides? Given all the complexities I just described, how do you see it making positive strides and being meaningfully measured for patients and allowing for that shift to happen?
Right. So when you think about the concept of value-based care, it's probably the right way to pay for something, right? You should be paying for the outcome rather than fee-for-service, where if I screw up, I'm going to get paid more because I'm having to do more, right? So it makes sense. I think the challenge for value-based care is, what is value, right? Because value is what? Quality divided by cost, or that's the economic theory, right? We don't know what quality really is or how to measure it very well, right? So a lot of the value-based care right now is really focused on cost, right? Did we reduce 30-day admissions for CHF patients? That's really a cost-driven number, right? Because hospitalization is expensive. It's not clear it's quality, right? Because depending on the comorbidities of the patient, they may require hospital readmission. So that is the real challenge: is how do we measure quality in medicine and in terms of the outcomes that we have. Now, in terms of the positive, I think some of the initial impact of this shift towards value-based is that as a physician, I'm surrounded by people who can do things for patients much better than I have a care manager now, staff in the emergency department. I have social workers. I have pharmacists providing more support. There's just a lot more support because I think health systems have figured out that if we're going to shift to value-based care, we can't rely on the physicians to do everything. There have to be experts in different things, whether it's managing the patient's medications or managing or coordinating their care to sort of get to that value point. So I think that's one of the good things, but we're still figuring out how to measure quality, and that's a real challenge.
Yeah. Dr. Steele, we spoke with you briefly about this topic, and I know you have very passionate about this, but I think you bring a very interesting perspective from more of a rural setting. And maybe you could speak about some of the implications or challenges in a rural setting that are different or unique to those in more urban or large healthcare systems.
Yeah, well, thanks. From a rural standpoint, rural areas typically deal with bad payer mixes. Most hospitals in rural areas have less days of cash on hand, and what they're at a distinct disadvantage when you deal with value-based care because it requires more overhead. And as most people know, all the programs that do value-based care don't really communicate all that well. So CMS has different rules than the private insurers, than the employers. And so it requires more overhead and more staff to be able to do that, which strains your tight margins even more. So in rural areas, I think you end up having definitely an uphill battle. Some of the benefits, though, that you do have is you do in a lot of rural areas have the people that have survived thus far have learned to pinch pennies and get reasonably efficient. Usually you're smaller and a little more nimble. And so what you're able to do potentially is get by on those margins already. And I think you can sometimes in rural areas actually flip the script a little bit and look at areas where you can expand into that potentially may have better payer mixes than what you're currently looking at. And you can actually deliver an efficient, lean care to those specific patients and potentially be able to expand your market area once you can really crack this value-based nut. So I think you're posed with a little bit of a challenge to some degree in a rural area, but you're also have some potential hidden abilities that once you figure this out, you may have a strategic advantage.
So that's an interesting point, thinking about how some companies have figured that out within their own institution. And so kind of moving to the next question here, Dr. Ellsworth, you've worked at many different types of institutions, and how do you see consolidation of different forces, for lack of a better word, impacting healthcare today for patients and providers? So examples would be new consolidation of companies like CVS and Aetna, or otherwise different groups coming together to provide that.
Sure, great question. I think we don't know the answer yet. I think we're still in the infancy there. I think it's Amazon is going to deliver medicine to your front door by some robot. I mean, all of these things are sort of happening, and CVS taking over with teaming up with Aetna. I think there are good things and bad things with any of these types of mergers. Let's start with the concerning or the bad. As a physician, when I get an email from the Texas Medical Society saying one insurance company is merging with another insurance company, the first thing I think of as a provider is a monopoly where they're price fixing the things that I can do as a surgeon. So I get very worried, and I work on advocacy in my other time to try to prevent price fixing, which is more commonly done when there's monopolies like these. And so fewer payers, especially in a particular zip code, they can simply decide who's going to be in network and who won't, and sort of box out the physicians, especially a guy like me who does breast reconstruction. Some of the other concerns I have when you see these sort of monopolies develop or bigger brothers taking more of the pie is R&D, or research and development funds. Historically, more competition allowed for a higher degree of research, development, innovation, because it sparred new ideas, it created new things. And when there's fewer people running the pie, then there's less motivation to create those new research and development funds and drugs, surgeries, devices. I think the good side of it, those are my concerns that first come to mind. The good side of it is these providers bring things to healthcare that we've never had before, right? We've never had Amazon in healthcare. We've never had CVS really delivering healthcare. Really, you go there to get your reflux medication and then you go home. But now you can go see a practitioner there. I think they bring a customer service that we've never seen in healthcare before. I think they bring an innovation in technology as far as delivering healthcare that we've never seen from an Aetna, a United Healthcare, or even a major hospital system like Houston Methodist, which I work with. So those are exciting things. Virtual health, all of these things that are taking over the market in Texas. We, as a hospital system, have had to try to keep up with the CVSs and the ones coming down the line with the virtual doctors. And now we have appointments regularly open on your iPhone. So that's the future. I think it's yet to be seen how much of the good and how much of the bad comes to reality.
Yeah, I think one of the key pieces of this is the changing expectation of the patients and consumers of healthcare today. Kui, you mentioned a little bit some of your experiences, especially in a very tech-savvy community. So what does it mean to you as the expectations of our patients changing? What are the implications or challenges? What does it mean to you as to provide a coordinated care for the patients?
I think definitely time. Coming from Silicon Valley, we have CEOs who they want to be on their phone every minute. They want to send the last email. We just took care of a lawyer who just wouldn't get off his phone until the time he goes into his OR room. And as a freestanding facility, and with the patient experience, we will accommodate that. And we know kind of everyone lives on their phone, and we have phone chargers for them. just things like that. Make sure they have Wi-Fi, make sure they're connected. If they want to make calls, they can make calls. We're on their time. We see surgery as, whether we do plastic surgery too, and whether, you want to do plastic surgery so you can get, either skinnier or better looking, but it's still an inconvenience. We see it as an inconvenience. So how do we, decrease the inconvenience to get them to where they want to be? So that's really what we see.
The other you're talking about consolidation in terms of the large payers and different providers. The other consolidation that is happening is actually physician groups are increasingly becoming commoditized, right? So Blackstone owns a large national physician provider organization. So they have anesthesiologists and they have ICU doctors and emergency physicians. And how that's going to play out is not clear to me, because at some point the investors are going to come calling for their return. And how that will play out for physicians, we don't know, but people aren't aware that this is happening, and practices are being bought by very large organizations that are profit driven. And we'll have to see how it turns out.
Mm-hmm. Yeah, I agree. Kind of circling back to thinking about how this is affecting patients at the end of the day, and you're mentioning some large payers, you're mentioning providers. So to push it back to you, Dr. Ellsworth, how might payers as well as providers be more disruptive in healthcare in a way that's going to benefit patients?
That's a big question. So I think from a patient experience standpoint, and I think plastic surgery is a perfect example where patient experience and catering to the patient is still critical. I have patients that come to me for breast reconstruction that I'm their third person they're interviewing for an insurance-based procedure. This is the reality of healthcare, at least in Houston where I live. So how do we team that up with what's coming, which is value-based care, and how do we make them think in a disruptive manner? I think one idea, at least in my field, again, breast reconstruction, is value-based care is so good at thinking at a big picture level, but they don't necessarily think about the practices or the particular specialties. So while they want us to communicate, and you get points for communicating with other doctors and about patients, they don't necessarily support or incentivize practices such as ours, where we sit down at a table with a radiation oncologist, a medical oncologist, a breast surgeon who cuts away the cancer, and a guy or gal like me who rebuilds the breast after cancer. So that's an interdisciplinary approach to breast cancer, which we've proven in the literature gives patients better outcomes, better psychosocial outcomes, and treats their cancer in a better way. Their recurrence and their livelihood is better when they come through a team approach. So it's harder for insurance companies to monetize that, or they haven't really done that. That's one way that they could. They could look at teams like this and realize the benefit and somehow organically support those systems, which I don't know that they do yet. That's one idea, at least within the field that I practice in.
Dr. Steele, any comments about who is at risk or who faces the biggest challenges in the value-based, like which of the stakeholders as we transition to these kind of value-based models?
Well, I think everybody knows that one man's waste is another man's profit. And that's something we got to remember in this whole value-based system. And so when we talk about waste, you've got to realize that that could be somebody's profit there. Anecdotally, in my experience, we entered into the bundle payment, the BPCI program, bundle payment for care improvement with CMS, and we reduced in one service line SNF, or skilled nursing facility utilization, by about 50% and home health utilization by 80%. I'd say they didn't win that game. Those guys didn't win, home health and SNFs in that. They got kind of multiple problems. One, they lost the easy patients, so that hurt revenue. And plus they're left with the high risk people that they have lower quality on, and it requires more work to do it. So it's just, they lost. But it isn't just those provider entities. You also have losers at a bigger scale. Qui works in surgery centers, and you see some doctors getting involved in surgery centers, taking total joint for knee replacements, moving them from a hospital setting to an ASC, saves money. Your DRG payment for an inpatient procedure is about 30% less if you do it as outpatient, so it saves everybody money. Well, the hospital just lost the top end revenue on their healthiest patients, and now the hospital's left with the high-risk people that are harder to take care of and have lower quality. So the hospital lost in that win. So functionally, I'd say the people that lose are the people that are passive, that play defense. And the people that win are the people that are active and play offense. And Bear Bryant said that offense sells tickets, defense wins championships. But in this specific setting, I think defense is going to win this. Defense is going to lose this one, and you got to be on the offense. So
I would add just briefly to that, I think those are great points. And the other losers, unfortunately, are private practitioners or the sole. You've explained that physicians are being driven into employed medicine, whether it's academic or more commonly now employed by medical systems like the one that I work with and am employed by. But it's harder and harder to find people who can actually sustain a solo private practitioner life in surgery or in medicine for that matter, because the regulation within value-based healthcare and the dollar amount required to achieve those goals and to document those goals with IT needs is so high. So it's almost, they've tried in value-based care to make it more reasonable for them, and there are attempts to make it more palatable, but it's very hard these days for those types of physicians to stay afloat.
Just to add to that, from the patient perspective, I think there's two trends under value-based care. One is the narrowing of networks, right? Now that's driven more by cost, but that's under value-based care. And the whole issue in terms of balanced billing that's now come up, this is all driven by the narrowing of networks and the narrowing of choices for a patient. So the question is whether the patients are going to accept this narrowing of choice, that you can only go to certain places and otherwise you have to pay for it, or somebody has to pay for it if you're outside of that. The other risk is for these high-risk patients. I think patients with chronic disease and complicated chronic disease, there is some risk for them in terms of being in narrowed networks or not being able to get services, or in truth, the payer is saying, these are not really the lives I want to take care of because they're expensive. And I think there is some risk for those higher risk patients.
Mm-hmm. Yeah, I agree.
And we see that too at the surgery center. Our docs want to bring our patients here because they know that they're going to get better care, quicker care, more efficient. But we have to cancel cases because of the narrow of the payer mix. And these big monopolies, they're happening in the Bay Area also. You're either academics or you're Kaiser or you're county. Those are really the big three.
Mm-hmm. Mm-hmm. It's interesting to hear you guys talk about all of these shifts and how care is coordinated, whether you're in a private practice or you're working in a multi-specialty practice in that way. It's interesting to sort of reflect on not only how care is being coordinated different from a provider standpoint, but when you're talking more about the who's at risk from a patient standpoint, it is exactly what you're describing. And so I want to shift a little bit into how is that going to be changing consumerism in healthcare? And I use that word cautiously, and I know that there are lots of different definitions of that, and I don't want to lose the empathy of what it means to deliver care to people. But when we think about the word consumer and really understand that, like even just in our research, we go in and we really understand all these different aspects of people's life, and expectations are really changing because their lives are changing, and so they're placing some of those same expectations on healthcare. And it's not just the needs and values, but it's really like the nuances of how people place meaning on that and how they connect that to the complex relationships that they have with technology or receiving care in different ways. And so when we think about all these patients who are at risk or potentially at risk in the future, how can we make sure that we don't just create standalone products or create more chasms, but people are now taking some of that information back from providers. So traditionally in the past, providers really held on to that information, and now it's really shifting towards patients. So Dr. Ellsworth, I look at you a little bit to really try to understand how do we really not lose that personal touch with these changes, but still provide what they're looking for as a consumer?
So I think that is going to be a challenge in the next sort of decade of medicine, because we're pushed as practitioners, as surgeons, medical doctors, to produce. And the productivity level that our goals are go up and up. So there is only so much time in the day, yet we still want to and should be doctors for patients that take care of people. And these are women who show up in my office just coming after their diagnosis of cancer, a single mom of a 3-year-old from yesterday's clinic. So these are impassioned, sad stories that you can help, but you also have to document an epic. You've got to check all the boxes. So the PQRS value-based system gets me paid. I have to make sure she has the right in-network insurance and her network's not so narrow that I'm pushed out. So the doctor and the provider in the clinic is faced with all of these struggles, yet our goal should be and is to provide appropriate, safe, and ethical care, but be compassionate to these people. And I find that one of the hardest things at the volume I have to produce at. Things that I do to help, I don't document in front of patients ever, period. I have to hire more people. I have 2 PAs and a cosmetic nurse, and they do a very efficient job with me in clinic, but I will never write, I will never type. I simply sit next to the patient and I sit close to them so that I can touch them and I can look into their eyes. These are simple little things that are proven to connect you to the patient so they feel, even if you're only there for a few minutes, they feel connected to you. Because I have so many patients and have such a busy breast reconstructive practice, I can't spend an hour and a half with each patient, but I can hire people to do it, and then I can come in for those critical, let's say 15 minutes, to teach them what I need to teach them and let them connect to the person who's going to do their surgery. But that's very important, and that connection can't end there. So I produce videos. I have a video company that comes in and videos testimonials and videos me, and we talk about my family and what I do, and my wife's a surgeon too, and those are going in the waiting area when my PA runs clinic so that they continually have a touchstone, which is the provider or the surgeon, so that they can feel connected to you, even though I'm in surgery, producing another widget for the administrators, but still they feel that connection. So I think there's nuanced opportunities there to duplicate yourself. Another example, I'm on the flight here. That's when I look at my patient mail. I had 3 lovely cards from amazing women who are breast cancer survivors, and I'll jot a little note. I mean, literally 2 sentences, and I attach it to the letter, and my administrative person will then send that off. But that little 3 sentences to a patient in my handwriting means the world. Mm-hmm. So I think you have to try hard to stay connected, mm-hmm. and it's becoming harder and harder.
Mm-hmm. I'll toss this out to anybody who wants to answer it, but it's so wonderful to hear those stories of just the true empathy in those moments. So with consumerism changing now, how do we do what you're doing really well with this proliferation of non-traditional healthcare settings when you're not necessarily face-to-face?
Is this for me again? Oh, God.
You're answering all the tough ones.
I guess, right?
Yeah, you did a really good job.
I don't know. I don't have a great answer. I will say, and I assume you mean non-traditional healthcare venues, meaning like over Skype when you're developing a doctor-patient relationship over the video. I don't know that I have a great answer for how to develop that, other than when I'm in clinic and there's a connection to the patient. And I feel like I could create that whether it's over video or whether it's sitting in front of you and talking only to you in the office. And that means your time is only with them when you're with them, and you're not documenting and you're not doing all the other stuff. You're not answering your phone. My phone goes off constantly. I don't ever look at it. I take it out, I hand it to whoever's assisting me, and they walk out because that person knows I'm there for them. So those little things, I think, translate over video as well.
I would add that I think consumerism is good, but there are some challenges in healthcare for patients to play their role as consumers, right? Because it gives them more choice, but with choice comes responsibility. Yeah. And they have to have a decent amount of knowledge. I can't keep up with medical literature in my specialty. So how do I expect a patient to be knowledgeable enough to make these choices as consumers? That's a real challenge. I think about the experience of my mom and my father and navigating them through the healthcare system. I can't imagine how somebody navigates the healthcare system without an advocate or a navigator. So I think there's 2 potential roles, one involving technology and more AI, perhaps assisting patients, and having non-physician navigators. Your office probably uses, all your offices probably use people who aren't physicians because they're too expensive, really. But you have somebody who calls the patient, how's it going? And then if there's really a question they can't answer, it's going to pop to your nurse or then to the physician, right? But you can't answer all of them. But having somebody who can help navigate a patient through the system is going to allow better consumerism.
And someone answering the phone.
Yeah.
This sounds stupid, but this matters. I go nuts when I had a root canal yesterday. This is a real story, okay? So I'm post-op, evidently. So I called, and he has this horrible phone tree on his, and I can't get anyone. I'm in surgery, you know, some nurses, it's just and so that is frustrating. So I pay more. I have 2 people at my front desk because I want a person to answer my phones, and that little thing matters.
Well, and I think a part of the answer to this too is sitting the administrator who considers you Dr. Widget Maker down to hear your story and your personalization, because as you know, as a business owner, investing in those things isn't just a gift you're giving to the patients. It's in your best business interest to deliver a great experience to your patients, and that's why you're investing in it. A, you care about them, but B, it's in the best interest of the organization to deliver that degree of personalization. And I think when the administrator hears, yeah, I'm not going to produce at the top decile, but you know what? Here's why. It's not because I'm lazy and I'm playing on social media the whole time. It's because I'm spending that extra time writing a letter and doing that. And you can tell because my HCAP scores are great. ER doctors love ED-CAP scores, so I know that you're a big fan of those. But see, passion. But you're going to see the fruits of your labor, and that's where I feel like when administrators can sit down with you and hear your passion and hear exactly what you said, I feel like that's when they can step back from the grind and the communication and say, you know what, you are delivering that, and that's something they see your practice is booked out, and they see that consistency and the high quality. And I feel like that's when you start realizing that to succeed in value-based person, you all have to be on the same team.
Mm-hmm. Yeah, I agree.
Yeah, and maybe as we think about this, because I think as Chris and I spoke with each of you on the phone, one of the themes or topics that came up across the board was not only are all these things happening real time today and looking to the future, but meanwhile, 2 things are happening where the education of physicians and clinicians isn't really changing or adapting to address those future or these existing challenges today. All of you spoke about the business side of things, the interpersonal skills, advocacy, things that you're involved in. So maybe talk, and second to that, this notion of staffing, nursing shortages, and how we kind of address these things. So maybe I open it up to anybody if that sparks some thoughts about how we think about medical education and how it needs to change to address these gaps or move towards the future.
I think from a medical education standpoint, I think you've got to start at the basics. And first of all, most physicians don't really understand what costs are. They don't know the cost that they're incurring. They don't know what the reimbursement structure is. They don't know the very basics. And I think once you understand that, then you've got to kind of dig a layer deeper and figure out what are the implications to the different players involved. Does this actually pass through? Is this extra cost on the hospital, or extra on the doctor, or extra on the patient or the insurer? Because just because you're using a higher cost instrument doesn't mean the patient is paying any more. It could be a hospital issue. And so a lot of times we don't know the implications, and even if we did, we don't know where they pass through. And I think lastly, once you fully understand those is when we can start determining truly in value-based care, are we really delivering value? I don't think the studies necessarily are out there to show, is this high cost instrument truly delivering value? And I think we've got to look outside of the medical community in itself and say, does this really reduce the future cost of healthcare? I think we've got to look outside of that to the society in general and say, does this improve productivity to the society? Does this add years to people's lives, and what the functionality is? And I think we've got to quantify that when we're looking at value and not just dollars and cents in the healthcare system. So I think you've got to kind of learn one step at a time to get there.
There's a big sea change coming in medical education, and it all started maybe 10 or 20 years ago with work hour restrictions, because being at a training program in an academic center, the residents who are coming now are going to be our doctors in 10 to 20 years. They are tech savvy, they are social media savvy, but they view medicine as a little bit more of a shift work rather than a full-on career. I mean, they are transitioning, they work their 8 to 12 hours, and they hand off the patient to somebody else. So in the future, when you're hospitalized, you're probably not going to have a single physician caring for you through the whole time, right? You're going to be handed off another team, another team, another team. So my joke is like, the AI and robotics better be really good in about 10 years when I'm a big healthcare consumer, because there's going to be physicians handing my care off to somebody else within 8 to 12 hours, handing off to somebody else in 8 to 12 hours, and so forth and so on. So that is really, I see that in the mindset of our residents. I really do. I don't know how.
I would agree.
Yeah.
I mean, I think it's shocking. I've been in practice 9 years, and I went through the transition of work hours when I was in residency, and my residency was 6 years long. And it was this interesting, there were no work hour restrictions, and I worked about 120 hours a week. And then there were work hour restrictions, and we had to document online, and we still worked 120 hours a week, but we didn't ever say it. So I mean, this sort of this fake decrease in hours, and now they're really taking it. And it's interesting, in the residents now that I train, I enjoy teaching residents, honestly, and they come to my community hospital where I practice. These are fellowshipped, they're finished with general surgery and they're becoming plastic surgeons. But they are not the same. I literally 2 weeks ago had a guy want to leave a double microsurgical free flap because his wine club had a meeting that night. So I could never have said anything like that. I mean, that's like unheard of to say.
Yeah.
But he was open, happily to discuss, if you don't mind, I'd like to leave early for this. I'm like, okay, I don't even know how to respond. So the idea of being a surgeon, the idea of being a doctor and spending the hours not only in training, but just taking care of patients, it's completely changing. I'm not saying it's all horrible, honestly. I think there was a lot of bad things going on in surgery in particular. I grew up in the hospital where DeBakey lived and trained. I remember DeBakey rounding. I was an intern. It was scary as hell. But those people lived in the hospital. That's what they do. And that's also not right. So a balance has to be achieved. And I'm not a good example of balance, I would say. But I think the pendulum has swung dramatically. I think it's going to come back because we're seeing that surgeons in particular all need fellowships because they're not coming out of their initial 6 years, let's say, trained enough to be comfortable doing the surgery on their own. And that's kind of scary, like you said, when we're consuming the healthcare system.
Right.
Yeah.
So, Worrell, you have a big task. You better make the robots really good.
We need to train them.
10 years.
So I just have one more question before we open it up to all of you to ask any questions. When you talk about shift changes, staffing demands, as well as shortages that we've discussed, prior to this, with all of that happening, knowing it's going to increase with baby boomers, and where would the stressors and opportunities be? So if we understand staffing is changing, there are shortages, but where can we really find opportunity in that with the aging population?
Well, I guess I'll start. So Jim and I are going to speak a little bit about the aging population, but I think non-physician providers is a growth area, whether they're assisted living providers or in-home care providers. That senior population is going to need that. So there's a lot of opportunity in that space because physicians are too expensive for a lot of the services that can be provided by non-physicians. So I think that is a big growth area in terms of staffing and where that'll go. And a lot of that may not even be people. It might be devices, it might be robots, that kind of thing. So I think there's a lot of gaps that can be filled with non-physician whatever to support this population. And I will say, the aging of the population is interesting because I think that we think, when in the emergency department, I see so many 90-year-olds now who are actually quite functional. I mean, retirement now at 60 or 70 means a whole nother life for people because people are going to live 20 or 30 more years and at a high functional level. We're seeing it. We're seeing it mostly with women initially because women are generally healthier than men. But it is impressive how people remain so functional. And fortunately, the psychology tells us that actually people in their 70s who are healthier are actually happier than people in their 40s and 50s, because a lot of the life stresses have been taken off of them, and they have some wisdom and experience, and that's what I'm looking forward to, hopefully. But there is a whole new set of, they call them super agers, but I think there's just going to be agers that are quite functional and quite productive in society and actually quite happy. So I think there's a lot of potential positive from a societal level.
I'll say that I think robots are great. I don't think they can do everything, though. You know, I think they're really useful, and I think they will become more useful in primary care, probably more so than other surgical subspecialties. In my specialty, I can easily do a virtual visit for a postoperative patient and use technology that way, but it's very hard in an initial interview to evaluate that patient. I actually have to touch their tissue. I have to physically be involved with that. And so it's a little bit different when you get into I would say the surgical subspecialties, or at least my specialty, to really disconnect completely from the interaction.
Yeah. Any final comments from anybody on the panel? Anything you feel like you need to share or say? I think, as you can see, we have a great luxury of interacting with these clinicians in the field, and hopefully this has given you a perspective of the things that they are faced with and challenged on a daily basis outside of just their practice, and really how each one of them is so well-rounded and has this experience beyond just their clinical practice. So, and also you can see like a lot of demands on their time, so we're deeply indebted and thankful that they could be here and they came here today, and we look forward to a fruitful future and continued collaboration with you. So thank you all. Thanks.